Good morning. I'm going to start giving you some information and will include what the migraine headaches are, how I discovered migraine surgery, how this surgery works, who is the candidate, how we detect the migraine trigger sites, the potential risks, the recovery, the success rate, and we'll have some time for answers to your questions. Migraine headaches are usually moderate or severe headaches that can be one-sided or involve both sides. Commonly are associated with nausea, vomiting, fear of lights, fear of sounds, and they generally last somewhere between 4 to 72 hours. There are 35 million Americans who have migraine headaches. And in fact, 1 out of 4 households has someone with migraine headaches. It is that common. Let me tell you about how I discovered the surgery for migraine headaches. A patient of mine, actually a prominent surgeon's wife who had undergone forehead rejuvenation, came for a follow-up. And this was about 6 months later. She told me, not only I like the way I look, I haven't had migraine headaches since you operated on me. I thought that was a coincidence. About 2 weeks later, another patient told me the same thing. So after hearing these two stories, I designed a study, and I'm fortunate enough to have researchers around me all the time. So we used the team and went back and looked at the patients who had undergone forehead rejuvenations and collected information. And there were 314 patients who had undergone forehead rejuvenation that we enrolled in the study and included in the study. And out of those, 39 had migraine headaches and 31 of them had either complete elimination or significant improvement. And in the migraine surgery world, we consider significant improvement when the patients have at least 50% reduction in severity, frequency, and duration of migraine headaches. And this study covered about average of 47 months, which meant that whatever we're doing and it is working, it wasn't temporary. But this was a retrospective study, meaning that we went back actually analyzed the results. And in medicine and surgery, we look at the evidence level. Evidence level is a gauge that tells us how important, how strong this study is. On the scale of 1 to 5, this was 4, but we needed stronger studies. So I thought about it and thought, well, why is the surgery working? Well, what are the reasons for a forehead lift to change migraine headaches? Fortunately, about that time, we discovered that actually Botox works on the migraine headaches also. And when I put these two pieces of information together, the only commonality between these two pieces of information and two treatments was the fact that we were eliminating the muscle function on one part, meaning Botox, paralyzed the muscles meaning frowning muscles. Surgery eliminated, removed the muscles. Although we have learned since that actually the vessels also have a significant role in migraine headaches that I'm going to talk about a little bit later. So we designed a pilot study. Pilot study means a small group of patients who undergo surgery to learn about the kinks in this study and make the future studies more effective and stronger. So on this part of the study, and I always work with a neurologist doing these studies because I'm not a neurologist. I don't make the diagnosis of migraine surgery. And we actually use Botox on this group of small group of patients, injected Botox first to see if they respond. They would respond to the Botox injection, and if they did, we included in the surgery. And we operated on 22 patients. 21 of them had either complete elimination of migraine headaches or significant improvement. And one actually did not respond to the surgery. The question was, why didn't the surgery work on all of these patients? And when we questioned these patients, actually we learned a great deal. And we found out that on the sites that we operated, the headaches were gone, but they had headaches in other sites. Up to that point, actually, the migraine definition did not include any anatomical assignment, meaning forehead, temple, back of the head. So we discovered that this was actually a turning point, and we discovered that headaches can arise from different sites. And as a patient, you can attest to that. And if you have noticed that sometimes the headaches start from different areas. So we focused on it and found that actually some of these headaches are coming from the back of the head, some of are behind the eye, some come from the temples. And we anatomically investigated all of these sites and came to the conclusion that there are at least 4 common trigger sites that we can focus on. And I designed an operation for each one of them. And some of these surgeries, which are just alteration of the existing surgeries that, as you already heard about, like forehead lift procedure, that we included in the study. Again, a neurologist helped me. I created a team of researchers that we could focus on the operation and attain results that would be reliable. And every time that we have done any study, we have made sure that we look into the risks first. And it is crucially important that when we do something, we make sure that the risks are worth doing the surgery. We didn't want to harm the patients. And as you can see on this slide, almost everybody has some numbness, but it was temporary, went away. Some had dryness of the nose, some had intense itching of the forehead, and in about 8% of the patients, 7 out of 89 patients that we included in this study did not respond to the surgery. And I'll tell you a little bit later what is that we do for those patients. So on this study, 92% of the patients had either complete elimination of migraine headaches or experienced significant improvement in the headaches. And we used 10 tools. These are research tools that document other things beyond the pain. Obviously, pain is one factor, but for example, getting back to work is another factor, quality of life is another factor. So those are the tools that we used, and every single one of them demonstrated significant improvement. The conclusion was that the operation is effective and it is safe. And we published this article in the Journal of Plastics and Reconstructive Surgery going back to year 2005. So the beginning was the year 2000. So, and over the last 20 years, we have done a number of studies. And one of the studies was about, do these results last? And yes, we actually followed up some patients for 5 years, and they remained migraine-free, or improvement that we achieved lasted for 5 years. So it is not a temporary change in the quality of life and headaches on these patients. One of the most important studies that I did is try to discover what are these migraine headaches about? Why do these patients have migraine headaches? The others don't. And what we did is took a small piece of nerve, obviously after getting a consent from the patients, on patients who had forehead headaches compared to those who did not have migraine headaches. There was 15 patients in each group, and through very reliable scientific methods, we were able to demonstrate that patients who have migraine headaches genetically are missing a membrane around the nerve that is called myelin. Again, myelin is like an insulation around the nerve, and essentially the patients of migraine headaches have naked nerves that muscle contraction, vessel pulsation that ordinarily would not cause any headaches are causing headaches with these patients. And again, this is a unfortunately genetic disposition, and most of the time family history about migraine headaches positive, meaning most patients have family members who have migraine headaches. And this, for the first time in the neurology field, demonstrated some cause and effect relationship. And we repeated again other studies. Uh, Now, we also have shown through these studies that migraine headaches work on adolescent patients as well. So we have done over 40 studies with different levels of evidence. And the most important level of evidence is a randomized surgery that includes sham surgery, meaning some patients underwent real surgery, some patients had the incision, the cut, and we went down, but we didn't change the anatomy. And when you compare those two patients, it gives you the most reliable evidence that we have in medicine and surgery. So through that kind of a study, we have demonstrated that the surgery works. Not only we have done these studies, 5 other reliable surgeons, including one of the Harvard hospitals, have done the same thing, same studies, and demonstrated that surgery is effective and it is safe. Now, for the last 10 years, we have been focused on how we can improve the results. What is that we can do to minimize the invasiveness of the surgery? Even though what I do, as we will discuss, is outpatient procedure and the patients go home after the surgery, we wanted to make these operations even simpler. And we also wanted to see why we are failing. If we are failing on 10% of patients, or some of the patients who have improvement and do not have complete elimination, why is that occurring? And we have discovered that the most common reason for failure of the surgery is the inability to detect the trigger size from which the headaches are starting from. This is like a domino effect. One branch of the nerve gets irritated, and it sends some substances within the nerve that they get to the brain and cause the headaches that would include nausea, vomiting. And we are focused on it and discovered each one of these trigger sites. And that of all the things that I teach internationally to the other plastic surgeons, one of the things that I stress the most is detection of the trigger sites. It's like having a map. If we don't know where we're going to, we can reach the destination. But the process actually starts with a neurologist, meaning I have never operated on a patient who did not have a diagnosis of migraine headaches by a neurologist. So the neurologist detects the trigger sites, and then most patients that I see have been to many neurologists, have had all kind of even procedures, insertion of nervous stimulators, with failure. So they already have seen migraine neurologist. And we ask them to maintain a log of their headaches for a month before they come to see me. Then we detect the trigger sites by using these constellation of symptoms that I'm going to talk about in a minute. And I'll ask the patients to point where they're starting from. And usually the patients can help me to detect that trigger site very precisely. And but we don't rely on that. There are other things that we use, including a nerve block if the patient has pain at the time. And I'll tell you in a minute what the nerve block is. And I'm going to tell you what the ultrasound Doppler is and CAT scan of the sinuses. But we don't order CAT scan for every patient. Can you point to the area of the pain? Yeah, perfect. Just keep it there. Let it go. So that is a Doppler. You saw that a small device, and it detects blood flow. It detects the heart beats. And what we have discovered that many of these headaches are initiated by irritation of the nerve uh, by the adjacent vessels. So the pulsation in the vessel is irritating the nerve and beginning these migraine headaches. And analyzing, as you can see, 1,200 patients that I had operated on, going back to actually several years ago, we have discovered that there are seven trigger sites. Some of them are common, some of them are not so common. And this has helped us to obviously serve many, many patients. Now, I mentioned the nerve block as a tool for us to detect a trigger site. Nerve block means injecting numbing medicine in where the headaches are starting from. Now, if the patient has headache at the time of office visit, this test is useful if the pain goes away. But if the pain doesn't go away, doesn't mean a lot. So if the patient has migraine headaches, obviously the headaches start from the forehead. But you remember I used the word constellation. Constellation means collection of these facts that I have in this slide, where the headaches start from, when they start from, is it stress a factor? And when I ask them to frown their muscles, do they have strong frowning muscles? Many of these patients have deep lines, 11s that is common term that it is used by public. And sometimes the eyebrow sags or eyelid sags, and usually have tenderness where they start from. And they respond to the Botox commonly. And again, on this side, the muscles that you see here, when they contract, they're irritating the nerve and beginning this a cascade of events that results in inflammation of the membrane around the brain. And if the headaches are in the temple area, we're going to have a nerve but irritated by the muscle that is called the temporalis muscle that opens and closes the jaw. And in this site, the pain obviously will be in the temple. These are the patients that commonly wake up in the morning with headaches because they grind their teeth at night. Stress is a factor. They commonly clench their teeth, and Commonly, they are tender in this area when we touch it. And many of these patients have what is called TMJ syndrome, meaning temporomandibular joint syndrome. And those two go hand to hand. The other common trigger site is behind the eyes. Headaches arise from behind the eyes, and commonly these patients have more headaches when the weather changes, when they lie down, when they have their periods, and uh, their noses run when they have the headaches. Now, many of these patients can actually predict the weather, and if you have it, you know it. And the reason that all of these factors cause headaches is inside the nose, we have projections called turbinates. They become larger when the atmospheric pressure is low, and it causes more intense compression of the nerves or irritation of the nerves. And these are those projections that I talked about. These are called turbinates. If there's contact between the turbinate and the partition in the middle of the nose that is called the septum, it's going to trigger headaches. And this is very, very common. The fourth most common site is the back of the head or occipital area. Many of these patients have headaches starting from back of the head. It is commonly related to distress. Common, and also it is very common for these patients to have had whiplash injury. The muscles are usually very tight in the back of the head, and the area is tender when we touch it. So this is the nerve that is called the greater occipital nerve, again passes through the muscle to get to the back of the head. And the muscle and the vessels surrounding the nerve cause headaches. So you may question, okay, what is that we do? Many of these operations are, as I mentioned, outpatient, and some, as I will stress later, are done under local anesthesia. The patients go home the same day and go back to work actually the same day or the next day. But some are a little bit more complex. If the patient has exclusively frontal migraine headaches, I'm going to use a tiny incision in the upper eyelid in the crease. So it is an incision that after it heals, you really have to look for it to be able to see it. And sometimes we look for it, we can't see it. So it heals extremely favorably. If the patient has combination of forehead and temple migraine headaches, we're going to use 5 tiny incisions in the hairlines. Each of these is about half an inch, and they heal very nicely. And ironically, when these patients undergo this operation, not only become migraine free, they actually look more rested. And when they try to frown, they can't create the lines between the eyebrows that you see there. He's another patient. You can see how deep these lines are before the surgery. And here, after the surgery, the forehead looks a lot smoother. You remember this is how we discovered that the surgery works. If the patient has exclusively temple migraine headaches, we have 2 ways of operating in this area. Either I make 2 incisions in the hairline, as you see right there, or we use an incision right on top of the tiny incision, right on top of where the headaches are, and remove the vessel and release the tiny nerve. And patients have pain behind the eyes, they have deviated septum. This is a partition in the middle of the nose that should be straight up and down. You can see it is tilted to the left. It also have this white area showing bone that is protruding into this structure, and that is called a spur. And it can irritate the lining inside the nose and begin migraine headache. These patients, when we operate on them, not only they're migraine free, they also can breathe a lot better. In the back of the head, we make an incision here and go down, remove some of the vessels, some of the muscles, free up the nerve, wrap the nerve with a fatty tissue. I don't remove the nerve in this area. The recovery is usually very short, and even with the most complicated cases, the recovery is about a week socially. Some of these patients that we operate on the forehead may develop some bruising, swelling around the eye. That goes away in a week. And we tell them not to participate in heavy exercises, strenuous activities for 3 weeks after the surgery. But as I mentioned earlier, many of these procedures are done under local anesthesia, tiny incision. They can go home immediately. They can go back to work if they want to. Definitely resume the normal activities the next day. But that cannot be done on every patient. We have to choose the patients more selectively. The success rate is something I'm confident that you are interested in. And as I mentioned, not only I've done this study, there are many studies, over 40 studies, others have done. We are seeing similar results, somewhere between 80 to 90% success rate. In my hands, there's about 50% complete elimination and additional 40% reduction, at least 50% reduction, which adds up to about 90, 92%. And that is after the first operation. However, we can actually go back and remove some of the irritants and operate on additional trigger sites that we may not have known about during the initial surgery. Remember what I said, part of the reason that we can't help every patient is because some of these patients have more than one trigger site or several trigger sites. And when the pain is intense on one site can actually mask the other sites. So we go back, occasionally we go back, and there are patients that I have operated on more than once, but I'm tenacious, I don't give up. And I also am committed to every patient to do my best to take away their migraine headaches. And our team doesn't give up easily. And the last 20 years have culminated to writing this book that I wrote about migraine surgery. And this surgery has become so prevalent now that not only I've written a book about it, a book has been written in Europe, and another book just came out from the United States again, 3 books. And I'm involved with 2 of those. Obviously, this one is completely summary of what I have done over the last 20 years. In summary, I have discussed with you what the migraine headaches are, how I discovered this surgery, how this surgery works, who is the candidate, how we detect the migraine trigger site, the potential risks, the recovery, and the success rate. And I'm ready to answer some questions. So there was a question from Florida, and I must say that the question was, how is that I can help her? In general, approximately half of my patients, whether I do migraine surgery or facelift, nose surgery, facial rejuvenation, are from out of town, out of country. So we offer Skype and FaceTime consultation. And the patients come in town the day before surgery once. We operate on them. They go home in a day or 2, and we follow up through Skype or FaceTime. So there's only one trip. But I also can help some patients to find another surgeon in the area if there is a surgeon in the area that I trust. I have trained many surgeons. The next question is, will I immediately know if my surgery worked? That's a great question. Unfortunately, the response rate is different from different locations, and it also differs from patient to patient. But a good number of our patients may have migraine headaches the night of surgery. Remember, we are around the nerve that is causing the headaches, but the day after, from there on, they don't have any headaches. But we don't judge about migraine headache surgery outcome for 3 months, because particularly when we operate inside the nose, it takes time for the headaches to go away for us to be sure about the outcomes. Um, the next one is, this is another good question. Will the surgery affect my expression? The only ill effect that actually only effect that the surgery has on the expression is positive. Remember, I showed you the patients who when they frowned, you couldn't see the lines. That is what we get. Actually, not only the headaches go away, the lines go away. Other than that, there's no ill effect of surgery on the facial animation. Next question is, does migraine surgery ever have to be done more than once? The answer is, as I mentioned, yes. And that is, if we fail to detect all of the trigger sites during the initial examination. As you remember, I mentioned that sometimes the pain that is intense masks the other trigger sites. But when we eliminate the main pain, the others show up. We make every effort to detect all of the trigger sites and operate on the patients only once. Next, does migraine surgery still work if the nerve block doesn't work? That's another wonderful question. The answer is yes, it would work. Let me tell you again about, repeat my statement about nerve block. Nerve block is numbing the tiny branch of the nerve where the headaches start from. So when we numb that nerve, and if the headaches are active and isolated to that side, or especially in the beginning, the headaches may go away. But if the nerve is inflamed completely, the headaches may not go away. The way I describe this to the patients, I draw a resemblance between the headaches and a tree catching on a fire. The headaches are the result of irritation of the nerve that is called the trigeminal nerve. It's like a tree goes like this. And if one branch catches on fire, it is possible that the other branches are going to be caught on fire soon, again, like a tree. Now, if imagine this is occurring, you're watching actually a tree catching on fire, and you see a branch is catching on fire, you pour water on it. What's going to be happening? You're going to stop the whole tree catching on fire. That is the response that we get, the positive response that we get to the nerve block. But if by the time we bring the water or have the water to pour on, and the whole tree is on fire, we pour water on that branch, we're going to kill the fire on that branch, but the rest of the tree is on fire. That is exactly what happens. And finally, the last question is about the Botox. The question is, can surgery work if the patient doesn't respond or wouldn't respond to Botox injection? The answer is yes. Actually, Botox doesn't work in all of the patients. In fact, think about it. I mentioned that some headaches arise from behind the eyes that originating from inside the nose. When we inject Botox, we don't really inject inside the nose. Even if we inject, it may not work anyway. So Botox, the fact that Botox doesn't work does not mean that surgery is not going to work. Well, that concludes this webinar. I hope that I was able to share some information that enlighten you about this dreadful condition, especially on this such a difficult time that they can get worse because the stress increases the migraine headaches. And I hope all of you safety. Thank you very much.